So good morning and welcome to day 2 of our digestive diseases update. Today we have two sessions. One is on pancreas and the second on IBD. The first speaker was Shanti Swarup Vege. So Shanti is the president of the American Pancreatic Association, and this week is is a pancreatic week that's going to happen in Hawaii. So he was here on Friday. He left yesterday morning, but he did record his presentation for us. He's a professor of medicine and pancreatology at the Mayo Clinic in Rochester and an internationally well recognized and reputed gastroenterologist. So he was supposed to talk on fluid management in acute pancreatitis, what, when, and how much to administer. So can we have his recording?
Good morning again. Thanks to my friends Rob, Shyam, Uday, and the team to give me an opportunity to speak to you today on the fluid management in acute pancreatitis, what, when, and how much to administer. Disclosures, federal research from NIH and Department of Defense, and the royalty from UpToDate for writing chapters on acute pancreatitis. Some of my personal contributions in the last 30 years in this field, reviews for very important journals, some of the new entities described that helped the classifications, and the book chapters in important resources, and many national and international guidelines, most of them as the senior communicating author. The only effective treatment available in the initial 48 hours of AP is intravenous hydration. But yet, we know very little. My friend John Windsor from New Zealand wrote this review in 2013. Fluid therapy in acute pancreatitis is anybody's guess about the various aspects, like which fluid, what rate, and what goal. So the basis for intravenous hydration is there are a number of reasons why you have third space losses. These include nausea, vomiting, poor intake, increased perspiration, as well as inflammation and capillary leak from the pancreas of the fluid into the peripancreatic tissues and entire retroperitoneum. That leads to hemoconcentration. Usually we take a cutoff of 44% hematocrit and above. But the reason why I put the chicken or egg here is, as you will see, the hemoconcentration then causes impaired microcirculation of the pancreas. But is this impaired microcirculation because of the increased inflammation, or the nausea, vomiting, they actually caused impaired microcirculation and then in turn makes the pancreas leak more fluid into the retroperitoneum? Regardless of this, the reduced perfusion and ischemia of the pancreas and peripancreatic tissues happens, and that causes pancreatic and or peripancreatic necrosis, which, as we all know, is not good, and that is what we want to prevent. So, a schematic representation that we used in our recent ACG guidelines is the normal pancreas, when you get acute pancreatitis, becomes edematous interstitial. Then the fluid started leaking into the peripancreatic tissues due to capillary leak. Then ischemic changes in the pancreas develop due to impaired microcirculation. And the hope is when you give intravenous hydration immediately when you diagnose this disease, probably we can prevent and make those ischemic changes better and revert back and then to normal state. And if we don't do that, that's going to lead to necrotizing pancreatitis. So how did intravenous hydration enter into the treatment of acute pancreatitis. One, of course, is expert opinion in any area of medicine where there is no level 1 evidence by way of multiple strong randomized controlled trials. Then the laboratory experiments in mice showed the effect of hydration in a positive way. Then there is a lot of clinical indirect evidence by showing people with increased hematocrit, BUN, not having good outcomes, which was also shown in the epidemiological studies. And then there are several retrospective prospective studies looking at the intravenous hydration in people with poor outcomes versus good outcomes. This is how people felt intravenous hydration is something that is very useful in this disease. The important factors that we need to really discuss in this intravenous hydration, which is the only therapy we have right now in the first 24 to 48 hours, is what type of fluid, at what rate, what's the total volume you give, and when do you start this therapy, and what is the duration for which you give this therapy, and during this time, how do you monitor? There are several ways: clinical, hematocrit, BUN, creatinine, urine output per hour, central venous pressure, and mean arterial pressure, which are invasive sort of things. The types of IV fluid we have are normal saline. For years and decades that we have used this. Dextrose in water or dextrose saline, very rarely when you are worried about the calories, but not common. The colloids, hydroxyethyl starch, there were some people who were enthusiastic that may actually be better, but when they did the randomized controlled trials, there is increased mortality, so strike it off from the table. And then the new kid on the block, which is getting firmly established and cemented, is lactated ringer. So why do we give lactated ringer in acute pancreatitis? This has been shown to cause better electrolyte balance and the outcomes in other inflammatory diseases. Then it also is supposed to be better pH balanced fluid than normal saline, which you know is acidic. pH is 5.5. Although both of them are isotonic crystalloids, and crystalloids is what we use in acute pancreatitis. So when you give normal saline, which we have been giving for all these decades without knowing much about the adverse effects, it leads to non-GAP hyperchloremic metabolic acidosis that causes renal injury. And you know that renal injury is independently present in acute pancreatitis because of the effect of cytokines like TNF-alpha, IL-6, IL-8, TGF-beta, etc. And now on top of it, we are also aggravating it in an iatrogenic manner. Then it also causes this acidosis and low pH will be there inside the pancreas. And inside the pancreas, acid pH causes more premature trypsinogen activation, which is the starting point in the inflammatory cascade of acute pancreatitis. So it worsens the inflammation and worsens the disease state. So lactated ringer is supposed to prevent all these things by not causing acidosis. Of course, you should be worried that the only time when you have to be cautious with lactated ringer is when you have hypercalcemia, because one of the problems with lactated ringer is it has calcium, and sometimes with excessive volumes the calcium levels can go up. So let's look at the evidence now with all this background that we discussed about why intravenous hydration, what type, etc., etc. As we already discussed that the only effective treatment besides other supportive care is intravenous hydration, a lot has been written in the last 20, 30, or even 40 years. But when we did an exhaustive technical review, in 2018 for American Gastroenterology Association, published as a technical review in gastroenterology, I, along with other colleagues, which formed the basis for the 2018 AGA acute pancreatitis guidelines. We did not actually find, when we did this in a systematic manner, any evidence to support anything at that time. In other words, there is no therapy, rate, whatever, that actually decreased the important clinically relevant adverse outcomes like development of organ failure, development of necrotizing pancreatitis, pancreatic and or peripancreatic, and mortality, and the need for interventions, etc. All we could show is only decrease in surrogate markers like CRP and systemic inflammatory response syndrome scores. Then Jim Buxbaum from University of Southern California, Los Angeles, who is a relentless acute pancreatitis clinical researcher, published this beautiful randomized controlled trial in gastroenterology, which showed the benefit of lactated ringer over normal saline on important clinical outcomes. My mentee and now a leader, Tim Gardner, did the prior study, the first study, randomized controlled trial, which showed decrease in CRP and SIRS, but not in clinically important outcomes. Here in mild acute pancreatitis, when they used lactated ringer in a RCT, they found there is a decreased ICU need and decreased hospital stay with lactated ringer, but no change in necrosis or SIRS, interesting. But at least we now are having evidence that it actually helps as far as the important outcomes are concerned. Then another, I can call a remote mentee, but Enrique de Madaria from Alicante, Spain, relentlessly pursued fluid therapy and with limited resources worked very hard to do a multi-center, multi-country randomized controlled trial using lactated ringer to address the question of aggressive or moderately aggressive. And this is the so-called waterfall trial in New England Journal of Medicine. Very famous trial. And here he convincingly showed in patients with acute pancreatitis, early aggressive fluid resuscitation resulted in a higher incidence of fluid overload without improvement in clinical outcomes. That's the important conclusion. A mentor will feel so happy when his or her mentees outperform them. And that's what Enrique de Madaria and Tim Gardner from Dartmouth here, who has been actually asked to write a review on the waterfall trial by New England Journal of Medicine, so you can see what a prestigious position that he is in. And he clearly mentioned that lactated ringer has been cemented as the type of fluid. But now what we need to do is to go over the waterfall and try to focus on drug therapy for acute pancreatitis to improve the outcomes. Then another mentee of mine, Alison Yang, wrote this review, and she summarized that there is insufficient evidence to state that goal-directed therapy. Now we are talking about how do we monitor. There is insufficient evidence using any of the parameters to guide fluid administration, that it reduces the risk of persistent organ failure, infected necrosis, or mortality. These are what we really want ultimately by doing whatever type of fluid therapy to be reduced. And also, there is insufficient evidence to say what's the most appropriate method for such goal-directed therapy. So in the guidelines, the most recent 2024, where I'm the communicating author, we suggested moderately aggressive fluid resuscitation. Additional boluses will be needed if there is evidence of hypovolemia. But still, By grade recommendation, it is only conditional and low quality evidence, despite the New England Journal of Medicine paper, because grade methodology is very strict. Also, lactated ringer over normal saline, once again, conditional recommendation and low quality evidence. So the key concepts we've stated in the guideline: all patients receive moderately aggressive IV hydration of isotonic crystalloid. Caution in patients with cardiovascular and or renal comorbidity. Monitor them for volume overload. Fluid therapy is likely more important early in the course of the disease, within the first 24 hours. Fluid volumes reassessed at frequent intervals within 6 hours and for the next 24 to 48 hours, with a goal of decreasing the BUN, in spite of evidence not being level 1, only weak. So the practice parts finally, rate is non-aggressive, aka moderately aggressive, 1.5 ml per kg per hour. In a 75 kg person, approximately 110 ml per hour. 10 ml per kg bolus if you have hypovolemia at the time of diagnosis. Type, lactated ringer. Timing, start immediately when you make a diagnosis of acute pancreatitis. Monitoring, clinical, hematocrit, BUN, creatinine, hourly urine output. Duration, 36 to 48 hours only. So the future studies should address large number of all comers with AP, regardless of severity. They should validate moderately aggressive lactated ringer treatment. And most important is decrease in the severity of the disease, local complications, morbidity, and mortality in randomized controlled trial by that type of IV hydration. Thank you.
Thank you, Santhi. Delighted to introduce our next speaker, Dr. Hernandez Barco. She runs the pancreatic unit up at MGH. One of her interests has been autoimmune pancreatitis, which I think is very misunderstood. As I've told her, I think her before, I wish I had $1 for every IgG4 that was ordered. I'd be a millionaire. Take it away.
Thank you so much to the course directors and also the course organizers for a really wonderful event. As he said, I'm Yasmin Hernandez Barco. I'm a medical pancreatologist, not an interventional endoscopist. And I developed an interest in autoimmune pancreatitis after I had a few patients as a trainee flare, and so I really took an interest in this disease. These are my disclosures. I will note Amgen is one of them. So my objectives today are to provide an overview of the various clinical subtypes of autoimmune pancreatitis, go through the pathophysiology of type 1 autoimmune pancreatitis or IgG4 related disease, and then go over some of the management strategies, especially for type 1 autoimmune pancreatitis. We classically think of autoimmune pancreatitis as a fibroinflammatory disease that's been divided into two broad categories: type 1 autoimmune pancreatitis and type 2 or idiopathic duct-centric pancreatitis. Even though they both impact the pancreas because of an immune activation, they're a little bit different in their presentation, with type 1 autoimmune pancreatitis primarily affecting men. There's an equal gender distribution in type 2, and in a recent study published by our group, interestingly, men tend to present 5 years later than women, and probably that's due to the fact that men have more pancreatic and renal involvement compared to women that have more head and neck involvement. Both of these diseases are very steroid responsive, but one of the features of type 1 is that you have a very, very high relapse rate. And so, as I mentioned, type 1 autoimmune pancreatitis is a manifestation of a disease called IgG4-related disease. IgG4-RD can impact essentially any organ in the body, and most patients, when they present, will have about 60% of patients will have irreversible damage of the pancreas, so excretin insufficiency, diabetes, and so trying to figure out this diagnosis is quite important. There are international consensus guidelines on the diagnosis, but the high-sort criteria developed by the group at Mayo Clinic is probably the easiest to use in clinical practice. It uses histology, imaging, serology, presence of other organ involvement, and a response to steroid to help make that diagnosis. It was developed for AIP, but can also be used for IgG4-associated cholangitis. So I'll start with histology. One thing that's very important to know is that to make a diagnosis of autoimmune pancreatitis, you do need a core biopsy, so you need architecture. That being said, usually core biopsies are being done to rule out a pancreatic cancer, not necessarily to make a diagnosis of autoimmune pancreatitis. And so if you do a fine needle aspiration and not a core biopsy and you have IgG4 positive cells, that does not mean that it's IgG4 related disease. I think that's very important because IgG4 positive cells can be seen in pancreas cancer, PSC, cholangiocarcinoma, and so to make that diagnosis of AIP, it has to be a core biopsy. Briefly, there are 4 classic histological features that can be seen if you biopsy any organ in IgG4-related disease, and that's lymphoplasmacytic infiltrate, obliterative phlebitis with sparing of the arteries, a storiform fibrosis, which is sort of a cartwheel-like fibrosis that you only see in this type of pancreatitis, and the presence of IgG4 positive cells in the pancreas. Every organ has a different ratio per high-powered field. In the pancreas, it's greater than 10. I'll emphasize here that you have to have a wonderful pathologist that you work with. I really believe in a multidisciplinary approach to this disease because it can be a bit tricky. The second diagnostic criteria is imaging. So you need a really good radiologist also. Classic imaging can make the diagnosis of autoimmune pancreatitis in about 40% of cases. It cannot tell the difference between type 1 or type 2. And some of those classic features include diffuse pancreatic enlargement or the sausage-shaped pancreas. Whenever you see a very long pancreatic duct stricture without downstream dilation, beating of the pancreatic duct, the halo sign, and a CT scan of the abdomen always asking to look at other organs in the abdomen. Is there renal involvement? Is there retroperitoneal fibrosis? And so when looking at imaging, you'll either have mass-forming or focal autoimmune pancreatitis or diffuse involvement. Diffuse involvement can look like other forms of pancreatitis, but with mass-forming or focal pancreatitis, it really does require a biopsy because this, even if you have a halo sign, I think you have to be very, very brave to not try to rule out a malignancy when you have a giant mass and a patient is presenting with painless jaundice, for example. And then I'll move on to serology. So it is called IgG4-related disease because there are very high elevations of IgG4 in the blood, and we see that in about 75% of patients with type 1, much lower than that in patients with type 2. But even though it's called IgG4-related disease, IgG4 is an immunoglobulin that really goes to the sites of inflammation, and so it may not be driving the pathophysiology of the disease as much. What I say, as Mel was saying, we get so many positive IgG4 levels and consults for autoimmune pancreatitis, and I think unless you really have classic imaging that suggests this could be autoimmune pancreatitis, I would be very cautious to use serology alone to make that diagnosis of autoimmune pancreatitis. And if it's checked during a period of acute inflammation, it can be very elevated. And so repeating that a few weeks later is very reasonable, and also using supportive blood-based markers like IgG or IgE that can also be elevated in the disease. Where IgG4 is actually quite useful is in predicting the risk for flare. So patients that have a very, very elevated IgG4 level, so in that 4th quartile, and actually also elevated IgE levels, these are the patients that are your highest risk for flare, so you may want to consider closer surveillance or potentially a different, or potentially maintenance treatment up front. I mentioned already other organ involvement, so I'll move on now to treatment. So the treatment approach for autoimmune pancreatitis or IgG4-related disease is first to induce and then maintain remission. And the indications for treatment is almost all patients. There's 1 or 2 that maybe you monitor with, but essentially any patient with pancreatic involvement with symptoms, persistence of a pancreatic mass, if there's cholestasis or elevations in LFTs when the bile duct is involved. I didn't talk about it, but happy to talk about it more during the discussion. And those that are at risk for severe irreversible organ failure, and the pancreas and the bile duct are 2 organs that really are considered high risk. Steroids are very, very effective, as I mentioned, in inducing remission for type 1, but there's a very high relapse rate. The treatment I almost always use is prednisone 40 milligrams per day for 4 weeks, and then I'll taper by 5 milligrams each week. Especially if there's bile duct involvement, I'll use that higher dose. But something that I always take note of when I first meet a patient is, do they have their bile duct involved? Do they have very elevated IgG4 levels? Do they have persistent IgG4 level elevation despite steroid therapy? And do they have other organs involved? Because those factors really do predict relapse rate, and so they need to be monitored very closely. And very low dose steroids are sometimes used for maintenance therapy, not necessarily here in the US as much, but there is some data for that, and the relapse rate is a little bit lower, but it is long-term steroid use for patients. I'll briefly talk about immunomodulators. If they work for your patient, that's wonderful, but it's very hard to predict which patients are going to respond to which immunomodulator. You do need higher level dosing, IBD level dosing. You need to do frequent monitoring because there are a lot of toxicities that can be involved. And I would, and any kind of immunomodulator or maintenance therapy can be considered for high-risk individuals. So I'll pause here. This is one of my favorite slides in talking about IgG4 disease, but I'm going to talk just briefly about B cells. So B cells are an immune cell. They start in the bone marrow, and early in their lifespan, they'll have CD19 expression on their surface. Later in their lifespan, they'll develop CD20 expression, and then as they move on to the periphery, they start losing CD20, and then later on they lose CD19. So you have a larger population of cells that have CD19 expression on them. So this is a brief overview of the pathophysiology of IgG4 related disease. So you have, these plasmablasts or B cells that are presenting antigen to a CD4 cytotoxic T cell, and it's those T cells that are driving a lot of the inflammation, fibrosis, and damage in whatever tissue they're impacting. And they've shown that plasmablasts accumulate in the blood of patients with type 1 autoimmune pancreatitis compared to those that are healthy controlled. So these really are driving a lot of the disease that we see in type 1. I'll move on to biologic therapy right now. So rituximab, this was really an important discovery, I think, for this disease. And on the bottom, I sort of highlight the history of rituximab. But it's a chimeric monoclonal antibody. It binds to CD20 and it decreases B cell population. And so it acts here at the level of the B cell. And so it depletes this B cell population. And in this retrospective study, also done by the group at Mayo Clinic, they retrospectively looked at patients that received an induction therapy of rituximab and those that received induction plus maintenance therapy. And what they actually found was that patients that were on maintenance therapy had much less relapse compared to those that just received a single dose. I will say that we still don't know the perfect maintenance dosing for patients. It's probably individualized, but this shows us that especially those that are higher risk for relapse need some kind of maintenance therapy. There are infusion reactions associated with rituximab. The infection risk is about 20%, as it is with a lot of the other immunosuppressants. And vaccinations are important to consider before therapy. So now I'm going to move on to some medications that are not yet approved or are currently under study, but I think it's quite exciting. I've heard a lot that pancreas is where IBD was 15 years ago, which means there's going to be a lot of exciting things that are coming. So as I mentioned, rituximab works at the B cell. There are a lot of rituximab biosimilars that can also be used. Sometimes they're a little bit easier to get approved by insurance. They work at the same level. The next medication is a medication called inebilizumab. This medication is interesting because it's an anti-CD19. And if you remember, there are more B cells that express CD19 than express CD20. And this may be why some patients that are getting rituximab seem to have very frequent flares. They may just not be fully suppressed with rituximab. And so this trial was finally completed. And it was the first double-blinded, multi-center, placebo-controlled trial for IgG4-related disease. And one of the criteria was that you did have to have multi-organ involvement, so it's not pancreas-isolated disease. And less than a month ago, they published their trial results, which were actually quite positive. What they found is essentially about 10% of patients in the inebilizumab group developed flares compared to 60% in the placebo group. And the placebo group did receive steroids, so it was somewhat compared to steroids, but essentially the hazard ratio for flare was only 0.1, which is pretty incredible compared to the other therapies that we have. And here the biology on the side shows that inebilizumab really does decrease CD20 positive B cells in the blood. There were adverse events. They were similar in both groups. Most of them were actually related to COVID-19 infections, urinary tract infections. There was a couple patients that withdrew from the study. There was a patient that had anaphylaxis. This patient wasn't fully treated with steroids before the infusion. And then the infusion reaction is 4%. It wasn't a head-to-head study with rituximab, but it seems to be a little bit lower in this group. And the reason for that is probably because this is a humanized monoclonal antibody versus the mouse-derived rituximab. So these are a few other drugs that are under study. I'm happy to share my slides. In the interest of time, I will just show them. This medication works also at the level of B cells, but it's a B cell inhibitor, not a B cell depleter. Again, the patients that are included in the trial it's called the Indigo trial, they have to have multi-organ involvement. These next two medications are tyrosine kinase inhibitors. They also work to inhibit B cells rather than fully depleting them. These are earlier stage trials, but again, very interesting in kind of anchoring in the pathophysiology of the disease. One study that was going to be very exciting, I thought, was this SLAMF7 molecule. As I mentioned, the B cells and T cells work together, interact with each other through this surface cell molecule, but unfortunately the trial was just stopped because of lack of efficacy. So the treatment approach for autoimmune pancreatitis is steroids are very reasonable as a first-line therapy. There is a high relapse rate for this disease, for type 1 autoimmune pancreatitis, though it should be first line for type 2 autoimmune pancreatitis. It should be considered for patients with pancreas-isolated disease. But if patients have biliary involvement, multi-organ disease, very high IgG4 levels, or they've had a relapse, considering rituximab or potentially inebilizumab as upfront therapy could be considered. Here you can consider immunomodulators. As I mentioned, I've moved away from using them only because I find it very hard to predict which patients are going to respond. But if you have a patient that has responded very well to these medications, it's very reasonable to keep them on this. So just as a brief summary to this, relapse rate with steroids are very high. Rituximab should be considered for high-risk patients. There are a lot of new therapies on the horizon, so we'll see which ones come to fruition. But always remember that pancreatic cancer is more common than IgG4-related disease, so if you have that patient presenting with mass-forming autoimmune pancreatitis, always rule out that cancer. In the last 2 minutes that I don't have, I'll briefly review type 2 autoimmune pancreatitis and introduce type 3 autoimmune pancreatitis. So type 2, I won't say too much about it. It is associated with inflammatory bowel disease. About a third of patients will either have it at the time of diagnosis or develop it shortly after. But these patients are very responsive to steroids. And I will mention that PD-L1 can be helpful in the diagnosis. Briefly here, you can see that it's a different immune infiltrate. This is more of a neutrophilic infiltrate. Their patients will have very classic, what are called gel lesions. And PD-L1 staining can actually be quite helpful in diagnosing type 2 autoimmune pancreatitis if there's a question about that. We don't really see it elevated in pancreas cancer, and none of the patients that we stained with type 1 had this positive. So again, this is a concept, type 3 autoimmune pancreatitis is a concept that Dr. Suresh Chari introduced, and I mention it here because it is an immune-mediated phenomenon. So this is what's known as immune checkpoint inhibitor pancreatic injury, or potentially immune checkpoint inhibitor pancreatitis. And this is an autoimmune pancreatitis that's caused by immune checkpoint inhibitors. And the incidence is pretty low, and I get a lot of consults for elevated lipase or amylase in the setting of checkpoint inhibitors. I usually say continue treating. It's really only if a patient has pancreatitis that you have to consider stopping these medications. And this is a subtype of autoimmune pancreatitis that I would really avoid treating with steroids because it can impact the oncological outcomes. And it can happen anywhere between the onset of treatment up to 12 months out. Here's a nice algorithm with the citation there, and really is just the approach to how to manage patients with immune checkpoint inhibitor pancreatic injury. Here's our summary. Steroids are wonderful for type 2. For type 3 autoimmune pancreatitis, I would avoid steroids unless the patient really has more severe pancreatitis. And then I'm happy to take questions during this session via email. And I just want to emphasize it really is a multidisciplinary approach at our institution with rheumatology, radiology, pathology, and I think it's a difficult disease to take care of and diagnose, so thank you.
Fantastic, thank you. I think our next speaker should be known to everybody, Dr. David Whitcomb, prior division director in Pittsburgh, now more, I guess I'd say, an intellectual entrepreneur, but I think he's done more to help educate us on the role of genetics and the importance of genetics in pancreatic disease, and that's what he's going to touch on today. Pancreatitis, when to think about genetics. David, welcome.
Well, good morning. I really am going to talk about precision medicine, which is the future. Everyone's been talking about it, and it's some kind of AI thing that'll be out there, but it's not. It's just clarifying the components of a complex disease, and it needs to be managed by physicians with clinical decision support, and I think it'll be fantastic. The presentation today is at the Florida Digestive Disease Update. On the left, all other times on the top right is my email address, easy to remember, or on X or LinkedIn. These are my disclosures and competing interest. So what are the clinical features of pancreatitis syndromes? And the key is syndromes because it's a group of signs and symptoms that come together, but it doesn't describe etiology. So acute pancreatitis is described by sudden onset of pain, increased levels of pancreatic digestive enzymes in the serum, and features that are typical of inflammation on an abdominal image. Chronic pancreatitis is even more complex. It's usually inflammation lasting either longer than 3 months or 6 months or a year, depending on who you talk with. And it can include pancreatic atrophy, fibrosis, which is often a critical component, pain, duct disorder, calcifications, etc. So this is what I was taught about chronic pancreatitis when I was a youngster at Duke. It's caused by alcohol, and if the person denies it, they're lying. The critical features, I was told, was fibrosis with loss of function. But at the University of Pittsburgh, we put together the North American Pancreatitis Study, or NAPS2, and we found that fibrosis doesn't correlate with pain. Fibrosis doesn't correlate with exocrine pancreatic insufficiency. Fibrosis doesn't correlate with diabetes. It doesn't correlate with pancreatic cancer. It doesn't correlate with therapy. And imaging cannot be used to diagnose early chronic pancreatitis, which I'm going to argue is the treatable stage, and it results in a multi-year delay in diagnosis when it reaches an irreversible stage. Furthermore, the severity and clinical course of every patient is different. And if I ask for a vote on how many believe this, I think it would be unanimous. So the traditional approach is case control studies and null hypothesis significance testing. And there's an important paper in the New England Journal of Medicine that reviewed 100 years of research using the scientific method. And what they concluded was that chronic pancreatitis remains an enigmatic process of uncertain pathogenesis, unpredictable clinical course, and unclear treatment. And I wished I could publish in the New England Journal of Medicine with those insights. So what is the problem in managing diseases? And it's using the traditional approaches to define complex diseases as syndromes. You can't get insight into what's going on. So the diagnosis, if it's based on signs and symptoms, it doesn't tell you what the disease mechanism is, and the mechanism is important for treating disease, as we saw in the previous talk. Population case control studies results cannot be used to manage individual patients. So the challenge is patient variability, and the premise of precision medicine is that patient outcomes are improved and healthcare costs are reduced when patients are given the right treatment at the right dose for the right disorder at the right time. So precision medicine requires genetic testing, and this is what physicians hate. I'm going to tell you why you hate it, and in the future you'll love it. Patient phenotyping is critically important, and biomarker tracking are important. So these three come together to help figure out what's actually going wrong and what to do to help your patient. So there are two types of genetic tests, and this is important because this is a tremendous amount of confusion here. The first one is medical genetics. This is from the original germ theory of disease, and it focuses on pathogenic variants. So these are one gene that causes disease, they run in families, and genetic counselors are trained to counsel people who have one of these diseases, and I'll talk about genetic counselors near the end. Precision medicine, on the other hand, integrates multiple risk variants in sporadic conditions to guide treatment, and they are used by physicians. So the physicians then can use this to help people understand the cause of their disease, to prognosticate the possible clinical course, and to select the best therapy. So why is this important? So let's think about the context of genetic variants and what they do and why we have to integrate these things together. So acute pancreatitis, as we know, have many etiologies. Recurrent acute pancreatitis and chronic pancreatitis has many additional etiologies. The etiologies and complications involve multiple systems. Each system has one or more specialized cell. And they're specialized cells because they express unique genes for a function that they do that make them special. The genes are linked to specific cell functions, response to stress. The cells are express genes in specific amounts because they're parts of machines, and they express the genes under specific conditions. So it's a very well orchestrated system to make machines to do things. Genetic variants and environmental factors alter normal function of specialized cells under specific conditions. That is the problem that we need to be able to address in precision medicine, and it is going to be clarified exactly how we do this, and I think you'll enjoy what we've found. But on the other hand, how can treatment be determined using a case control study and randomized trials? So this is how we think about medicine in the current Western medicine. It's population-based, and the question is, what is the one external factor that causes disease that is found in cases and not in controls? That's how we find, germs that cause disease. And all Western medicine is based on this germ theory concept. All medical schools, by law, have to teach students in this paradigm alone, or they cannot have their students sit for the state board exams. It's the Flexner report, and if the school is not following the 1910 Flexner report, their students cannot sit for certification. So we're locked into a more than 100-year-old paradigm. What is the alternative paradigm? Well, in precision medicine, it's engineering-based, and which genes alter protein expression, the right amount at the right time, or their function in specialized cells that cause pathologic responses to activation or stress. So I'm a professor of biomedical engineering at Carnegie Mellon University, and it's wonderful because those students are engineers, and you give them a complex model with 100 variables, and they say, we can test that under 2,000 conditions in 10 minutes. And a physician goes, gee, that's impossible. You can only do one at a time. To do this, we have to know what the machine dysfunction is. And we need to know the list of the parts, what they do, mechanistic models, to be able to simulate dynamic functions and test what-if scenarios. So let's think about the pancreas. What are the parts, what are their functions, and what can possibly go wrong? Well, it's a very simple organ. This in the middle is the acini. At the top are the cells that make the enzymes, and the bottom are the duct cells that flush them out. On the left, you see the acinar cell, and to the far left, you see that there are specific genes that are expressed in acinar cells. Some can cause pancreatitis, the ones at the bottom are protective. On the right side are the duct cells, which is a fluid pump, and the key genes are CFTR, and a couple others that are protective as well. So if you find a gene mutation, you know which cell it's in, and you know what part of the cell process it's in as well. So let's look at acute and recurrent acute and chronic pancreatitis. So this is the Tiger O list, listed at the bottom, and there's toxic metabolic causes, idiopathic, genetic, autoimmune, recurrent and severe acute pancreatitis, and obstruction. So genetics is important, and oh my stars, there's dozens and dozens of genetic variants and combinations. But what's even more astounding is the other factors in red, such as alcohol, hypertriglyceridemia, hypercalcemia, stones, and cancer, are all genetic as well. So how do you organize the data for a single patient treatment plan? What this tells us is that the modern medicine, based on the germ theory, fails. A new definition and progressive model is needed in order to understand this, and this is precision medicine. So this is a model that a group of us from around the world worked on and published, and it is a progressive model saying that people are at risk where nothing's happening, and then all of a sudden there's an injury, triggers acute pancreatitis, and that sentinel acute pancreatitis event, or SAPE, changes the pancreas, making it hypersensitive to recurrent acute pancreatitis. Then you have a stage where it's kind of fuzzy and you don't know what's going on, which direction it's going to go. But if they continue to have injury and stress, you have early chronic pancreatitis and then end-stage disease. What's interesting about this is that we know that end-stage disease cannot be treated, and you really want to start therapy early to prevent the development of a disease that no one can cure. The other things that are interesting is that if you look at each of the problems, fibrosis, exocrine insufficiency, diabetes, pain, and pancreatic ductal adenocarcinoma, they're in different cell types. And we know what the genetics are for each of the cell types, so it helps us to break this down and think about it more strategically. So the overall pancreatitis syndrome is not just the pancreas. For acute pancreatitis, we want to think about gallstones, which are genetically predetermined, hypertriglyceridemia, which is genetically predetermined with environmental factors, genetic causes, hypercalcemia, and other. And likewise with chronic pancreatitis, there's so many other factors and cell systems that are involved to cause this syndrome. Even in acute pancreatitis is important. So what we see here at the top, if you have acute pancreatitis and go to the right, to the left, you see that there's early management. You can calculate the severity using genetic factors, but usually can't get the test back in 20 minutes and determine the etiology. But now we want to prevent recurrent acute pancreatitis. And the first thing we do is we look for gallstones. If you have a gallstone, you take the gallstone out. If there's no gallstones, we still take out the gallbladder if it's recurrent pancreatitis. And it's known that if a person without gallstones, that with recurrent acute pancreatitis, if you take the gallbladder out, you reduce the rate of recurrent pancreatitis. But 2/3 of the cases are unnecessary, and the person ends up with post-cholecystectomy syndromes or other problems. And like Peter Cotton, who is my first mentor, told me, he's never seen a successful cholecystectomy because he gets all the complicated cases. But if there's no gallstone detected and you do genetic testing, you know if they're at risk of gallstones or not. You know all the other genetic causes, hypertriglyceridemia, and also pharmacogenetics, so that your treatment approach will be successful. So when do you test? At the onset of symptoms, and you use it to select therapy. Yeah. So which genetic and biomarker test should be ordered? Well, you want to order a test to cover all these possibilities. But it's one test, it's the human genome, and you can pull the pieces out as needed in order to solve specific questions. And the other reason that's interesting is that you can actually have this online on a mobile device anywhere in the world in order to review it. It doesn't tell you everything, it just tells you what you need to know. We also know that there are a number of pancreatitis causes that are genetically determined that direct therapy, and we can start on that immediately. What's even more exciting is the area of pain etiology and management, because this is also genetically determined. This is a study we just did from our NAPS2 cohort, and we took the people with chronic pancreatitis and looked at their CT and tried to correlate with pain, and there was no correlation. But if you take the people with a high pain experience and low pain experience and compare the genetics, we found that there's a whole list of genes shown here that are associated with pain. What's interesting is they're in completely different systems, in the pancreas, in nerve development, in psychiatric stress disorders, and in controlling neuropathic pain. And it tells you where the problem is and which drugs are going to be useful. And so this is now in press in Journal of Pain. And so this is why you can't fix everybody with pain by an endoscopy or by one drug. There are completely different problems, and we want to give the right treatment to the right patient at the right dose at the right time. So now, here's our progressive model, and what we see is down at the bottom, each of these has specific genes that tell us which cell it's in and what's going wrong, and the progression throughout the whole system can be broken down into which variants are present. If a person has gallstone disease and has chronic pain, they don't have chronic pancreatitis, they have a chronic pain syndrome. Another person may have episodes of pancreatitis. They have celiac disease and fibrosis genes, so even though there's fibrosis, they don't have pancreatic exocrine insufficiency. Pancreatic enzyme replacement therapy won't work, but a gluten-free diet will. In other individuals, if they have duct cell disease and hypertriglyceridemia and diabetes, each of these are driving each other, but we can identify where the problem is and target it. Likewise, with pain, pharmacogenetics is critically important because our pain medicines and our antidepressants are all strongly affected by metabolic genes, and if we know those, they're actually effective for all other diseases as well with hypertriglyceridemia and diabetes. Those problems are also solved. How about genetic counselors? Well, what do they actually do? This is from the Mayo Clinic. If you want to look at it in detail, I put a QR code. They educate patients, physicians, and other care providers about pathogenic variants. They determine risk, they analyze family history, they educate individuals, and they advocate on the part of the patient for the insurance companies. Medical geneticists focus on pathologic variants that run in families. Precision medicine integrates risk factors that are not disease-causing in sporadic conditions to guide treatment. The problem is that this is so confusing. How can anybody do it? Well, basically you need a precision medicine report that tells you where the problem is, and then what would an expert do? That's why you guys came here. You wanted to hear what the experts would do with a specific condition, but you can't remember everything offhand. So I started a new journal, and actually Mel is an associate editor, called Systems Modeling and Advanced Report Technology for Medical Decisions, or SmartMD.org, SmartMD with a dash. You can look at it here. Here's our first journal that came out, and this Journal of Precision Medicine has peer-reviewed papers. This is an example of how Dr. Singh from Johns Hopkins manages pain in acute pancreatitis. But it's also linked to machine-readable codes, it's open access, and it can be subscribed to by precision medicine companies that want to make the link. So we've got some tremendous papers. Dr. Wilcox just published one on how to interpret fecal elastase. Dr. Hernandez-Barco has one on immune pancreatitis. We have one on the first 48 hours of treating acute pancreatitis. So the things you've heard about in this session, you can get them free of charge on this journal. And so these reports that you get from a company link to these clinical decision support tools. They cannot tell the physician what to do, but it links them with what an expert says they would do given a patient that is similar to the one being reported. So in real time, you can see what an expert would do with a complex case that you have the mechanism because the genetics and the other factors are integrated. So in conclusion, you can contact me anytime by email. I'm on X, and every time a new issue comes out of our journal, it's at David C. Whitcomb, and I'm on LinkedIn as well. Genetic testing is central to the management of pancreatic diseases. Genetic testing in the United States is often done by medical geneticists who can't tell you anything, which you probably already know. Acute pancreatitis and chronic pancreatitis are complex genetic disorders. Medical geneticists and genetic counselors are not trained in precision medicine. Clinicians practice medicine. There's only one precision medicine solution for complex pancreatic diseases now and medical decision support for practicing physicians, and I'm happy to talk to you about that as well. But the future is now. Thank you for your attention.
We will listen to the last recorded presentation from Dr. Vege. He's managing chronic pancreatitis beyond pain. So let's play the recording.
Good morning, everyone. Nice to be back in Orlando. Thanks to my friends, Rob, Shyam, and team. I'll be talking to you on managing chronic pancreatitis beyond pain, exocrine, and endocrine dysfunction. Disclosures: NIH and Department of Defense federal funding, up-to-date royalty for chapters on pancreatitis. Most months Mayo, this time used to be like on the left with snow, this time global warming, no snow till recently like this. Some of the things I'm going to speak are in the invited review for the New England Journal of Medicine that I wrote with my friend Suresh. CP, as we know in a simple manner, is first described by Comfort et al. From Mayo Clinic in 1946. Pathology is inflammation, fibrosis, and destruction of the architecture of islets. Clinically, patients have pain, exocrine endocrine insufficiency, and complications. Imaging shows a triad of calcification, ductal dilation, and atrophy of gland. Typical example, alcohol and smoking. This is the typical CT scan which you are familiar. All the three features: calcification, dilated duct, and atrophy of the gland. What are the main worries for a physician while treating CP? It is pain, pain, and pain. More than $500 million annually. But today we are going to talk about the exocrine dysfunction leading to insufficiency, then weight loss, and then nutritional problems. Endocrine dysfunction leading to insufficiency, which is frank diabetes. Along with these things will be low quality of life and high resource utilization. On the left side, you see exocrine dysfunction. Fecal elastase less than 100 micrograms per gram of stool, and fecal fat, if you have the ability to do, 7 to 15 grams. Then it goes on to exocrine insufficiency. That is frank steatorrhea clinically. Fecal elastase less than 50. Fecal fat greater than 15 grams per day. Protein calorie malnutrition. Fat soluble vitamin deficiency and B12 and other micronutrients like magnesium, zinc deficiency. On the right side is in the dysfunction stage, you have abnormal glucose tolerance test. And when it goes to frank insufficiency, it is called type 3C diabetes. Fasting blood sugar more than 126 milligrams twice, hemoglobin A1C equal to or 6.5, and random sugar equal to or more than 200, same as diabetes. The consequences of exocrine insufficiency are weight loss and sarcopenia. These are protein calorie malnutrition. Steatorrhea, which is typically bulky, foul-smelling, sticky stools with oil droplets. Fat-soluble vitamin and micronutrients, zinc, magnesium, B12 deficiency. Osteopathy, which is a combination of osteoporosis and osteopenia. And then you have an increased all-cause mortality, including cardiovascular, etc., in chronic pancreatitis. But we actually introduced a new concept, Suresh, I, and other colleagues. We staged the exocrine pancreatic dysfunction and we called it dysfunction, not insufficiency. And we have 4 stages here, as you can see. Stage 1 and stage 2 have no symptoms of steatorrhea. Vitamin A, E levels are normal. In stage 1, elastase is between 100 to 200, and in stage 2, it's less than 100. Stage 1, stage 2 don't require treatment. Stage 3 is when fecal elastase goes to less than 50, and the fecal fat goes to more than 15. Coefficient is less than 85, that means 15 grams or more per day. And here, symptoms usually are present, and the fat-soluble vitamin levels may be just low normal. Here you give PERT, enzyme replacement. Stage 4 is same levels of elastase and fecal fat, but in addition to symptoms present, the fat-soluble vitamins and the micronutrients, they're all low, and you have to also supplement them. So fecal elastase is a big problem. I want you to focus on this slide. It has low sensitivity and specificity. False positives if the stool is liquid. It's not of much use. Easy availability led to misuse of this test by all the doctors. Used in many patients with dyspepsia and diarrhea without any clinical suspicion of CP. This is the biggest problem. A false label of exocrine pancreatic insufficiency is given, which is a serious mistake. And large number of referrals to specialty centers of these IBS patients, dyspepsia patients. And it's very challenging to convince these patients by us that you don't have a pancreatic problem and EPI. So sometimes you have expensive ways of diagnosing it. I'm just showing you this is how the MRCP shows the dilated beaded pancreatic duct. But MRCP also, after the secretin, the juice comes into the duodenum and fills. And based on the level of duodenal filling, D1, D2 second portion, D3 and D4, normally all portions fill. But if you only have D1 or D1 and D2, then we call it not enough juice and possibly exocrine insufficiency. We don't use it, but I just wanted to show you because some experts are suggesting this may be used. The pancreatic enzyme replacement therapy, PERT, the landmark paper from de Magno showed that you have to have 90% destruction of the islets and the SNI to cause diabetes and steatorrhea. Normally, 300,000 units of international units of lipase are delivered in the human body to the duodenum after a meal. 1 international unit is equal to 3 United States pharmacopoeia units USP. So 10% of normal is 30,000 international units or 90,000 USP. However, you don't have to give 90,000 USP of lipase with each meal. If you give 36,000 to 48,000 with meals and half with snack, that's more than enough. These help improve the weight loss, decrease the discomfort due to bloating and cramping due to liquid in the bowel. Some evidence they may reduce pain, but they are not primarily given for pain relief. Important to note is no effect on the osteopathy and mortality has been shown convincingly so far. Side effects may be constipation, increased uric acid. For those with pork allergy, you can get hypersensitivity. And very rarely, if you give large doses, which I don't do at all, you can cause fibrosing colopathy with everything being bound up in the colon. And if you don't have insurance, it may be anywhere from $1,000 to $2,000 per month. This is the big problem. What is the goal of our therapy in EPI? Normal absorption is the goal, but it is never possible to achieve both. Fat and fat-soluble vitamins and essential fatty acids, protein, carbohydrates for better absorption. All we can achieve is sufficient absorption or improved absorption. That's all we can do. This paper shows the exocrine pancreatic insufficiency dosing guidelines for pancreatic enzyme replacement are so variable. This is a very recent paper. This shows the extreme variability both within and across disease types like chronic pancreatitis, cancer pancreas, pancreatic resection, etc. So there is a lot of research needs to be done to find the optimum dosage and recommendations. Now, when you do a survey of the PERT replacement in adults with exocrine pancreatic insufficiency, there is a pressing need for enhanced PERT dosing guidance. People do not have good idea. 30,000 international units means 90,000 USP units. People have recommended, but most of the guidelines give 40 to 50,000 USP lipase, and that I think is actually enough. One word about the metabolic bone disease. The frequency of low trauma bone fractures is similar to other diseases like IBD, celiac, and post-gastrectomy, where it is very common, osteoporosis. Reduced bone density in patients with CP has been published extensively. And important thing is, although the 25-hydroxy D3 levels are low in this, they are not different from the non-CP patients, because it reflects that most folks actually in the area studied, which are in the northern part of North America, will have low vitamin D levels. And there is no correlation of the osteopenia and osteoporosis with the EPI. This is another interesting point. And people are now saying you have to have baseline DEXA scan in CP, calcium and D supplements, and sometimes even people are very aggressive in saying anti-resorptive therapy with bisphosphonates. So this is a paper from the consortium that we are doing for 10 years now, NIH 9-center consortium in chronic pancreatitis called PROCEED. We showed that majority of subjects had osteopathy on DEXA scan, 56%. And osteopathy had a higher prevalence of traumatic and spontaneous fractures. However, once again, the 25-hydroxy-D3 levels in osteopathy and in non-CP patients is not that different. And Gabriele, my friend from Italy, has done this meta-analysis, and he said fat-soluble vitamin deficiency is frequent, but the studies are not so good. No apparent increased risk of vitamin D deficiency in CP compared to controls. Again, I have said this. And larger high-quality studies are necessary to estimate the actual prevalence. Now, these are some of the resources for you. The review in hepatobiliary surgery by Vikesh in 2023, and the AGA clinical practice update 2023 gastro. How do you monitor PERT? Steatorrhea, you can clinically is the best thing to see how the stools are improving. Improvement in weight, energy levels, cramping and bloating. Pain probably is not a good way to monitor. Bone pains may get better. And for sarcopenia, you can use the timed up and go tug test. That means you ask the patient to get up and go 10 feet to the door. And if they take more than 12 seconds, that means they still have sarcopenia. But you don't have to do mid-arm circumference for sarcopenia, triceps skin fold thickness for calorie malnutrition, hand grip strength for sarcopenia, or FE1 monitoring how they are doing, because FE1 will be unaffected by enzyme therapy. Very occasionally, if you have doubts, then you may have to do fecal fat while on enzyme therapy. Has it improved or not? Now, these are the various enzyme preparations we have in the market. All of them are coated except Viocase, which is hard to get, but it is uncoated. And there is some evidence that it may have better effect on chronic pancreatitis pain. But you have to give it with PPI because it is uncoated. Otherwise, the gastric acid destroys it before it reaches to one. Even for the coated, sometimes if they are not improving, you may have to give PPI. The dosage usually is 36,000, so you can manage it with either 3 capsules of 12 or 24-12. But the way that you should give them is one at the beginning and the rest through the meal, and not at the beginning or at the end. And there is a cartridge preparation which you can use for enteric feeds also. Laboratory monitoring we already talked, and fat-soluble vitamin, zinc, vitamin B12, magnesium. These are at baseline, but albumin and 25-hydroxy-D every year. And rest of the things, if they are abnormal, you can do it every year while supplementing. Otherwise, once in 2 to 3 years is fine. And fecal elastase and fecal fat for monitoring, rarely you need it. So tips are start with 24 to 36,000 lipase with each meal. At the start of the meal and through the meals, check that they are actually taking if they are not improving in their steatoria or symptoms. You can go up to 72,000 and very rarely to 96,000 units of lipase. Lipase is the most important thing because it is not present in any other tissues, whereas the carboxypeptidases and the proteases are also in the brush border. So lipase is the one that we always keep talking about. And if no improvement, add PPI. Still, if no improvement, check for SIBO that is causing the symptoms, which is very common in these people. If still there is no improvement, check the diagnosis. But don't restrict fats in chronic pancreatitis. That leads to essential fatty acid deficiency and fat-soluble vitamin deficiency and weight loss. Frequent small meals, low fat. Every prescriber should know that 10% of normal acinar and islet function are often adequate. Any amount of enzymes can never replicate physiology. In the Western world, the PERT is very expensive. Studies comparing placebo to PERT are done only to get the FDA approval of these things, and never PERT was done with another PERT. And there are many methodological issues in those studies, and that's why I'm saying going beyond 72,000 units of lipase is rarely necessary. Then we move on to the endocrine dysfunction, type 3C or pancreatogenous diabetes. 5 to 10% of all diabetics will have this. 80% are due to chronic pancreatitis of type 3C is due to CP, and up to 70% of chronic pancreatitis will have type 3C. And this is very brittle diabetes with hypoglycemia due to loss of alpha cells and glucagon. So this is the most dangerous thing about this. And if you look at the alpha cells, beta cells, delta cells, and PP cells in the pancreas, alpha cells produce glucagon, 20%. Beta cells, 75% produce insulin. Delta cells produce somatostatin, very rare, and PP cells are only 1%. So it's the loss of alpha cells that makes these people more prone for hypoglycemia. And if you look at the type 1, type 2, type 3, this table nicely tells the differences. And the main difference is the fasting C peptide is very low in type 1, low to normal in type 3C, whereas it is normal or high in type 2 because of insulin resistance. Ketoacidosis is common only in type 1. Hypoglycemia is common in type 1 and very frequent in type 3C. Islet antibodies are negative in type 3C. And of course, the continuous glucose monitoring will show hyperglycemia and hypoglycemia alternating in type 3C. So you have to do hemoglobin A1C every year when you're suspecting dysfunction, and then maybe every 6 months once they have it. It is different from type 1 and type 2, the type 3C. Pancreatic polypeptide response to meal is diminished here, and they're proposing it as a test to diagnose this. Hypoglycemia is very common due to loss of glucagon, and metformin or insulin are the drugs that are used to see. So these are the key points. Unique form of diabetes. Most common cause of type 3C is CP. They have greater morbidity and mortality because of hypoglycemic events, and insulin probably is the drug of choice. So I conclude my talk saying this funny slide that if you don't have insurance, you are toast. And with that, I conclude, and thank you very much.
So I've got two cases to present, and surprisingly, I met Dr. Whitcomb, David and Mel the same day, 6 years apart.
Case presentations.
Is there an audio problem? Okay. So I interviewed with you, David, in Pittsburgh, August 14th, 1996 for a JI fellowship. It was a Wednesday, cold morning when I came from Rochester, and I met Mel for the first time on August 14th, 2002. At UAB for a faculty interview for both gastroenterology. So I'm pretty good with dates. So I've got two patients to present. I selected these two cases because they were not correctly managed, and I thought you will provide some wisdom. So the first is an 89-year-old male who was referred because of acute epigastric abdominal pain, and he came with nausea and vomiting for about 24 hours to the emergency room. So he was actually a traveler somewhere from the East Coast, and he's got family around here. He landed up in the emergency room at a place called Claremont. His blood sugar levels were not being well controlled, and he was on metformin. He doesn't smoke, he doesn't drink. His white count was 7.1, and AST was high of 467, ALT was 40. His bilirubin was 3.8. At least biochemically, he didn't have pancreatitis. His lipase was 7. His glucose levels was 384. His CA99 that was checked in the emergency room for some reason was 108. He had a CT scan that you can see. It's actually got a dilated bile duct. Let's see if we can point it out to you. It's got a dilated bile duct here a little bit. It was about 8 millimeters, not out of the ordinary. The pancreas is pretty uniform. This is a cross-sectional view. There's nothing going on there. There was no mass, but you should look at the pancreas quite carefully. There is some sludge in the gallbladder. So he lands in an emergency room somewhere, and the local gastroenterologist was asked to consult on this patient. So because of his jaundice, he underwent an ERCP, and this is the cholangiogram. They also did an MRI, but it's a true to MRI that is done very often in Florida. It's a motion-limited study. They said there's a little bit of fluid around the pancreas, maybe a mild intrahepatic duct dilation, which is fair enough. So there was a stricture at the distal common bile duct that was appropriately brushed by the local gastroenterologist, and not surprisingly, it was non-diagnostic. The patient was then referred for an EUS examination. The patient came to us. Lay it down for you. So this is EUS of the pancreas. You can see the organ is a diffusely a black organ. That's a vasculature, that is a portal vein. I don't see any duct dilation. That's a body and tail view. Going to the head of the pancreas through the pylorus. And once again, you find a very similar examination. The structure that came to view was actually the bile duct. This is pancreas, and I'm actually looking for a solid mass to see if I need to sample this. Generally, what you do is you go to the place where the bile duct tapers down so that you want to exclude a cancer. So this is a 22 gauge biopsy needle that was used for sampling. We use pathology in the room, and I'm pretty good, and you can see it is just some little bit of fibrosis. These are not very atypical cells. They looked fairly reactive. And then specimen was sent in cell block to the pathologist. So this was their interpretation. This is a chronic fibrosing pancreatitis with a dense lymphoplasmacytic infiltration and fibrosis. And there is no obliterative phlebitis. They did an immunostain for IgG4, and it was positive for plasma cells. So they said the absence of significant IgG4 positive plasma cells and no involvement of the ducts makes IgG4 pancreatitis unlikely. A ratio was done, and the IgG4 IgG cell total ratio of greater than 40% is not present. In addition, there were less than 10 IgG4 plasma cells per high power field. They also said there is no granulocytic ductal involvement. So they usually, not all reports are this detailed, but usually when my biopsy is negative, I always tell the technician in the room to check for autoimmune pancreatitis. So this was done by the pathologist, and this is the interpretation that I had. So this is the QR code. So for those of you who want to take part in this poll, you can. Is this a type 1 autoimmune pancreatitis? Type 2, is this IgG4 related sclerosing cholangitis, IgG4 related disease, or chronic pancreatitis? I'm going to just stop here and ask our faculty, Yasmin, words of wisdom on what I have done so far, and what do you think should?
So I think it's always easy to give the talk and then you have the patient in front of you, and this is always how it goes. It's really quite a challenging diagnosis. I mean, some of the things that point to IgG4-related sclerosing cholangitis or IgG4-related disease is the fact that the patient had, step one, I always call my radiologist, but there was a little bit of thickening of the bile duct there, and very appropriately, the patient should have an ERCP, should have an EUS, and especially looking at this area, having isolated IgG4-related sclerosing cholangitis only happens in about 10% of cases. It does occur, but it's a little bit more rare to not have pancreatic involvement as well. The biopsy really is the gold standard for this disease, so I think the fact that it didn't meet criteria in terms of IgG4 positive cells, the ratio of IgG4 to IgG, it did have the lymphoplasmacytic infiltrate there. I still think that even though the biopsy wasn't entirely suggestive of IgG4 related disease, I still think it's a possibility to consider.
What do you think about the CT scan of the pancreas? Is that suggestive of type 1, just the way it looks?
Probably, we can go back to it, but I think there was some loss of lobulations at the tail and a little bit of that hazy fluid around it. I agree, there wasn't a mass that was there, but the bile duct I felt looked like a IgG4 related sclerosing cholangitis.
Sausage related.
Yes, exactly.
Yeah,
And that's the loss of lobulation, sorry.
Just a couple additional things. You've got two organs involved, so that makes it a little bit more likely, something like the type 1 AIP. Secondly,
Hello?
What is that?
Hello?
Jam?
Oh my.
Jam?
It's very scary, actually. The score
Yeah.
is with... Okay, it's done. Wow.
The CEA was elevated. The CEA was...
Can I?
Sounds like veggie.
The CEA 19.9 was elevated, and that's very hard to interpret. Part of it is because, of course, the genetics, the foot 2, foot 3, determine what the normal CA 19.9 levels are. So for me, my normal cutoff level is 89. That's hard to determine. Secondly, is that the CA 19.9 can be elevated with biliary disease. It's not specific either for the pancreas or for cancer. Thirdly, is the lipase level is very low, suggesting that they have pancreatic exocrine insufficiency with loss of acinar cells, but the pancreas looked fairly normal size. So my suspicion is that this person has had an IgG4 related disease for a long period of time, has developed pancreatic insufficiency because of this, and we're seeing sort of the residual effects.
And I just want to add one thing about the CA19-9, which I didn't mention. I've had patients with pancreatic cancer with IgG4 levels of 700, and I've had patients with IgG4-related disease have CA19-9 levels of greater than 1,000. So I love serology when it fits the picture, but by itself, a CA19-9 or an IgG4 is not a perfect way to rule in or rule out either condition.
I mean, the major concern for us always when we get these patients is you don't want to miss cancer. That's what really, really bothers us. So we'll go through the motions of it. So what will we do next? So this is the patient. I did an EUS, ERCP. Should I change the plastic stent for a covered metal stent? Check IgG4 levels, repeat the EUS biopsy in maybe 2 to 3 months, get an oncologist consultation, which you really have no control over consultations in community settings sometimes, and that's what happens. Should I get a trial of steroids for this patient? Trial of steroids. So he's 89-year-old, so you have to keep this in mind. He's about 89 to 90 years old. He doesn't want anything very aggressive done. Trial of steroids. So you think, Yasmin, trial of steroids is appropriate at this point with this limited investigation?
Yeah, trial of steroids is definitely reasonable. And in somebody where you're not entirely convinced that it's IgG4 related disease and there's even a little bit that you're still worried about a cancer, I do think a trial of steroids is very, very reasonable. I'll usually get repeat imaging at 3 to 4 weeks the latest. If I have a higher suspicion for IgG4 related disease, I'll let it go a full 4 weeks. If I'm really, really worried about a cancer, I'll do it, make sure a lot of that inflammation is responding. But I think trial of steroids is very reasonable. And it is part of the diagnostic criteria, though we try not to use it if we don't have to. But I think for him, he has enough features that it's a reasonable first step.
So Don't ask me why. So this was ordered by someone. They ordered his serum IgG4, immunoglobulin typing. So he had a total IgG of 2235. IgG4 was about 359. Everything was high except IgG2. But anyway, I started him on a tapering dose of prednisone, 40 milligram, to be tapered over a period of 4 months, and then he was discharged back. So he disappeared, went back to the East Coast, and then he came back for his ERCP at 4th month. So I removed the stent. It looked pretty good. The cholangiogram, there was no stricture now. At this point, he was getting off his steroids. Everything looked good. 6 months later, he's gone. Now he comes back. He now comes back with severe pruritus and jaundice. And this is his cholangiogram, which now looks quite obvious. In his intrahepatics, he's got multifocal strictures, and he doesn't have an extrahepatic stricture at this point. I restarted him on a tapering dose of steroids at 40 milligram, vitamin D and calcium. And the reason was because of his age. I was concerned that if I put him on rituximab at age 89, I don't know the implications of it, but I started him back on this treatment. Is this the right approach for this patient, or should I have done something different?
I think his age definitely plays a factor. I mean, if he's a very robust 88-year-old, living in Florida and, enjoying a very active life, sometimes I think rituximab for him might have been a reasonable next step. I didn't have him in front of me. And that's mostly because of the biliary involvement, not so much just because if he had pancreas isolated 100%, I would probably do steroids again and then maybe even try some of the immunomodulators. But the biliary involvement is so high risk, and that I do think something like B-cell depleting therapy might have been a good next step. Another thing that might have helped me decide is I would have trended his IgG4, IgG levels, because if he didn't fully respond, if his IgG and IgG4 really didn't come down all the way and they still lingered, that's another sign that he may relapse. But again, I didn't see him in front of me, and I understand the concern always in these situations, immunosuppressing somebody at 88.
That's important. Thank you. I mean, we learn sometimes very, very small things, but I did not know that following this IgG4 for treatment modification is critical.
Oh, I will make a point. The GI and rheumatology world are in great conflict about using IgG4 levels, and GI world doesn't always feel that they're that helpful, but we do see, and when we look at the larger cohort of IgG4 related disease patients, those patients that do have a good response to IgG4 levels, you can use it both as a marker for relapse. So if it starts going up, sometimes we'll check it at every 3 to 6 months. Those that don't respond all the way, they're probably going to relapse, and it's not a great marker. So we'll see where the two fields come together, but I've found it useful to trend IgG4 levels.
Can I ask a question?
Sure.
So many gastroenterologists, if they have an IgG4 related, refer the patients to rheumatologists to manage. What's your thoughts on that?
I think it depends on the center where you are and the resources that you have. And I think every possibility could work. So where I am, John Stone, who's a great leader in IgG4 related disease, he's there. He was running the infusion center at the time, so we set up a multidisciplinary collaboration where if a referral comes to me and they do need rituximab or biologic therapy, there were a lot of clinical trials, I do refer to them for management. But I know Vikesh Singh at Hopkins, for example, he does all of his own infusions. And I think a lot of it depends on your level of comfort, and if you're in the community, do you have your own infusion center where you can set up this medication, or do you have to refer out? I don't think there's a wrong way to do it. I think it's based on resources and availability.
Are there any other medications that we can consider, immunosuppressants for these patients like azathioprine or 6-MP? Do they have a role, or it's all outdated?
They definitely have a role, and I think it's so much easier to prescribe azathioprine than it is to get prior authorization for rituximab, set up infusion, pre-treatment. So I do think that unless you have the system already set up, it can be very challenging to get rituximab for patients. And then all the time you're waiting for this authorization to go through, they're sitting there on steroids trying to control their disease. And so in someone like him, azathioprine could be very, very reasonable. Just as we do with other diseases, you have to monitor. And if he responds to azathioprine, perfect. He can stay on it, and it's a very great choice. It's just, it takes some time to know if that's going to be the perfect medication for that particular patient, which is why I moved away from it. But in somebody at 88, I think it's very, very reasonable too.
I mean, I referred him to our hepatologist, and then he dismissed the option of azathioprine. He said he's too elderly to go on this medication, and he was worried about some immune-related, side effects and so on. So the patient has, I saw him only on last week. Let me see how he does. The second case is much more straightforward. So this is a 35-year-old female. She comes with acute abdominal pain. She's got nausea and vomiting for 18 hours through the emergency room. This is her third episode of acute abdominal pain. The first was 2 years back. She was diagnosed with acute pancreatitis. She was in the hospital for 5 days, and as usual, got the gallbladder out. The second episode happened exactly a year ago. She was hospitalized for 2 days, managed conservatively, nothing done. Now she comes to the ER with this episode of pancreatitis. She's not on any medications, she's just on contraceptives. Examination, she's got epigastric tenderness, her white count is 14.8. Serum amylase is elevated. AST and ALT are borderline high. Bilirubin is normal, ALK phos is normal. She had a CT of the abdomen, just an edematous pancreas with some trace peripancreatic fluid. The bile duct was 8 millimeters, abruptly narrowed above the level of the ampulla. She was given Ringer's lactated 150 cc an hour and was given narcotics. And so I wasn't convinced. She has got a stone on the bile duct. She was referred for an ERCP. It was an inpatient, so I just did a quick EUS examination of her pancreas, and that's the aorta. And as you pull back, it's pretty good actually. For an acute pancreatitis, it's a normal pancreas. You see a pretty good uncinate, and this is the dorsal duct as you're pulling back, looks normal. There's something funny about the pancreatic duct. I don't see the bile duct taking off anywhere nearby. So that to me is a minor papilla. So to me, it was none of her previous MRs had picked it up, but I was pretty convinced that the patient has got pancreas divisum, 3 attacks of pancreatitis now. So what should we do for this patient? 35-year-old, 3 attacks of pancreatitis, pancreas divisum. Should I just proceed with an ERCP and perform a minor papilla sphincterotomy and stenting? Do some genetic workup on this patient, get a celiac plexus block, conservative management maybe, and not do anything? David, words of wisdom for us?
Well, I would do the genetics. And the reason for that is that you can, we know that as far as gallstone disease, one of the major risks is being a woman of that age. I don't know what her BMI is. If she's had children, all those are risk factors, but there is very strong genetic component as well. And so if those all come together, I would think about recurrent biliary disease. Also, she could have genetic causes of this as well, underlying SPINK mutations or those things that put them at high risk. People with pancreatic divisum, they've got an outflow problem, so it's a plumbing problem. It's got 2 components. One is distal resistance, but if she has a CFTR-related disorder, she would have upstream problem with head pressure. She can't actually secrete it, so the combination is a problem. If that indeed is the problem, there are 2 things. First of all is a minor sphincterotomy to reduce the downstream resistance, and the second thing is to stimulate the CFTR function, which there's ways that you can do that. We know that CFTR potentiators are very effective, but they're $300,000 a year and not available now. So I think that covering the differential diagnosis with a genetic test is the first thing I would do, and then that would help guide further therapy.
And when we order that test, is there something specific that we should request?
Well, the beauty of the genetic test is that you look at all of them simultaneously and tell you which system is functional in this woman. So it helps you with your differential diagnosis because, gallstones have a different genetic profile, duct cells have a different profile, acinar cells have a different profile. Each of these things have, different subset of genetic variants that point to which cell is dysfunctioning and for what reason.
So this is very important. We are fortunate to have Mel with us for medical pancreatology. Generally, in day-to-day clinical practice, when somebody gets pancreatitis, people usually, nobody thinks about it. The multiple reasons. We always think about an endoscopic treatment option. We really think if it is genetic, then maybe it will help the patient's family. But here, there's really an important thing to note is that it has direct implications for that particular patient's care. So I did an ERCP on this patient. She had 3 attacks. I did explain to her that ERCP may not fix her problem, but since it's her 3rd attack, maybe a little bit of opening up the sphincter might help. So this is a 543 cannula with a 018 wire. So that's the minor papilla that you're seeing. And then this is probably Rob's very favorite tool for cannulating the minor papilla. So he trained us in Charleston, and this is the go-to device for a clear minor papilla treatment. And once the wire is, usually you put a small knot on the tip of the wire, and then you get a nice pancreatogram. And once that is done, the orifice is very, very small. So I decided to do a needle knife over a stent to be careful. So that is a 4 French stent. You don't want to leave a small, short stent. You want to take the stent all the way to the tail of the pancreas so that it doesn't fall off. There are no flanges so that it will fall off in 3 weeks by itself. And then you just expand the orifice by doing a needle knife over it. And then you just cut the inner tissue so that there is good flow. If you don't do an adequate sphincterotomy, the stenosis will be quite very tight that we won't be able to go back and re-intervene at a later time. So this patient is now gone. She came back, remained asymptomatic for 14 months. So 2 years back, she had an attack of pancreatitis. A year back, she had an attack of pancreatitis. Now she felt good for 14 months and then developed ongoing upper abdominal discomfort for about 4 to 5 months, even before she came to us, that progressed to another attack of pancreatitis. She went to a local emergency room and then got transferred to us for additional treatment. She says her quality of life has now significantly worsened over the last few months, and she's on tramadol, 25 milligram every 8 hours. So she was referred for an ERCP, but I elected not to do because you can just look at it and say it's all open. But when you do the EUS, significantly different. It's completely fibrotic. It's got a lobular appearance here at the bottom. You got these nice hyperechoic strands, which are markers of fibrotic tissue. I can't see the pancreatic duct, but it is razor thin. It looks irregular, and the margins are also very irregular. And this is how the entire gland looks. So this patient met all the criteria, 7 out of 9 criteria for chronic pancreatitis by endoscopic ultrasound. Now what do I do with this patient? Should I just do an ERCP and reopen the sphincter? Will it help? Should I just go for a celiac plexus block, prescribe him antioxidants and vitamins? I usually do this to all my patients, and Mel laughs about it. Or should I just refer this patient because she is young for a total pancreatectomy, not a diabetic, so maybe with an islet cell transplant? Or should I just manage this conservatively with dietary changes and medications? CP, wow, okay. I don't think, doesn't help, right? I mean, even in the first place, I'm questioning my wisdom for ERCP because it's a year and now it's happened again. She felt good for a year, but that could be just placebo effect, I don't know. And what should I do, David, next? Do you have any thoughts on what should be the next line of management?
Well, I still don't know what's causing this.
Okay. And should we do our testing, and how can we help this patient, even if something comes back positive?
Yeah, so first of all, I hate total pancreatectomy with islet transplant. Everybody gets a disorder afterwards. Sometimes it doesn't help them with the pain, and it's a miserable, expensive, and can be life-altering. They're also on maximum pancreatic enzyme replacement therapy for the rest of their life. So I would still would like to know what the underlying genetics is, and if there's anything we can do to correct it. I think that just making sure the minor papilla is patent is useful, but that's what I would probably do. I'd probably do that. So I still like to know what's causing it. So I'd still do. I would definitely do genetic testing before I sent them for a total pancreatectomy.
Okay, I mean, I think there is a push, at least from Minnesota, that everybody should get a total pancreatectomy. It's falling out of favor. I don't think it's a very popular concept. They do it in Miami here, but there is a celiac plexus block study that is ongoing. If you look at the meta-analysis, it's about 67% treatment response. But again, all the studies have not been well done. Mel has written a very brutal editorial about it in CGH long back. He doesn't believe in it. So that's exactly for the reason we are conducting a sham-controlled randomized trial ongoing. We have enrolled about 21 patients looking at celiac plexus block. We don't know if it's going to be helpful or not, but those are the cases. Any additional words of wisdom, Mel?
Yeah, just a couple of points. I think you looked for a stone before, and she had pretty rapid progression of pancreatic changes. So I would underscore what David said. I think this is an underlying genetic problem all along. I guess the second thing I would say is, although David did bring up minor papilla sphincterotomy, that's actually controversial whether it works or not. I think you appropriately told the patient that it may not work rather than, oh, I'm going to do this and it's going to fix you, because oftentimes it will not fix you. And even though the patient did well for a year, a number of patients do well for 1, 2, 3 years before they have another attack. So really following somebody long-term is important. The last point would be, unless you do adequate therapy of the minor papilla, you can get stenosis and you can develop a whole nother problem because of your endoscopic therapy.
Please. No, please go on.
While I have you here, it's more of a statement on my approach, but a question if I'm doing it right. So I have a lot of young patients that are referred for idiopathic pancreatitis. I had a 65-year-old male that I diagnosed with cystic fibrosis just before I came down. And when I have a patient that comes in with recurrent acute pancreatitis, it's critical. I'll always ask about a family history of pancreatitis, history of pancreatic cancer, history of cystic fibrosis, undiagnosed pulmonary disease. If there is that strong family history, I do refer to a genetic counselor. Even though I'm at an academic institution, it's very hard to get to them to do sort of the 6 major genes. But for everybody else, I talk to them about the aerial precision medicine, which you haven't mentioned, but that's from the testing, and I tell them that pancreatitis is a multifactorial disease, and yes, they were drinking alcohol, but there may be something that predisposed them because everybody that drinks doesn't get it. And when I send this testing for risk variants, I find things essentially every single time. And of course, for a lot of them, I say don't drink, don't smoke, high antioxidant diet, low processed food diet. And sort of those are the modifications we can make. But for some, I find CFTR mutations that actually do meet criteria for cystic fibrosis or cystic fibrosis-related disorder, and they qualify for therapy. So that was a very long way of saying that that's sort of my approach and how I'm counseling patients, and I'm curious if you counsel them in the same way, or if there's sort of an improved way to do that.
Well, as I presented, I think the etiology is so important before just doing random therapy. And even pain therapy, many people cannot activate the pain medications, or they'll can't clear some of the drugs that we use as neuromodulators, and they get toxic responses from them. So just having clarity how to manage the patients based on some of these variables that are common among patients. And actually the FDA recommends that everyone get an evaluation for these, I think 270 drugs that we commonly use. I know for people with IBD, they often do that, but this extends to other diseases as well. So I feel much more comfortable if I know what I'm treating and come up with a plan that addresses 1, 2, or 3 problems. I think the other thing that's interesting is there's a high overlap between pancreatitis and celiac disease. And as I mentioned in my talk, we're seeing often is people that are diagnosed with chronic pancreatitis and pancreatic external insufficiency that have nothing wrong with their pancreas and have celiac disease. And the appropriate therapy obviously is not pancreatic enzyme replacement. It's a gluten-free diet, and they get better.
Thank you. So we will conclude the session here. We'll meet back at 10 o'clock for the last IBD session. We've got a fantastic lineup of speakers for the last IBD session. So let's take a break and reconvene at 10 o'clock. And thanks for the speakers. It's a good session. Thank you.